Today I have a collection of MRI GIT cases. Please concentrate. Each case has a different scenario of the exam. Again, I will tell you. One case may be related to research satisfaction. Another case, subtle finding. Another case, scenario case. What mean by scenario case? Um, like syndromic cases. Okay. So concentrate, number one. Number two, don't satisfy of searching within each case. Let's start. Candidate one.
Yes,
Hello?
sir.
Yeah.
Yes, sir.
Yeah. Request control, please.
Requested.
This is 2 months female patient complaining of abdominal distension, diarrhea, and vomiting. 1 second, I will remove this one. 1 second. 1 second. Let's start.
Okay, so I'm presented with a CT scan of the abdomen of a child, 2-month-old, with abdominal distension and diarrhea. I would like to have a general look before starting my comments. So, the study is done with IV contrast, arterial phase. There is a diffuse abdominal distension. This is the most upper cut. The heart is unremarkable. There is no pleural or pericardial effusion. The liver is homogeneous with no focal lesion. There are abnormal hypodense lesion involving the center of the abdomen, involving mainly the retroperitoneum. It is surrounding the aorta and elevating it away from the vertebral body. The aorta is patent. I would like to check for the rest of the vessels and the extent of this lesion. So, going down, multiple calcifications involving both adrenal glands. Could be due to neonatal hematoma or hemorrhage. And these hypodense masses are encasing the vessels, namely the superior mesenteric and the celiac. However, patency is still preserved. They are encasing the vessels with no mass effect, no calcification. So my differential, no renal mass and no adrenal masses, no bowel obstruction. These are likely to represent lymph nodes. So at this age, I would be concerning about lymphoma.
What else?
Okay, the congenital lesions are teratomas, Wolff's tumor, and neuroblastoma, which are not the case.
Again,
So,
what is your area of concern? What is your concern? Where?
Okay, it is
Show me.
here.
What is this?
Yes.
Show me by the cursor, please.
Okay, this area is abnormal. These soft
No.
tissue lesions are abnormal.
No, this is bowel.
So,
This is bowel.
okay,
Use the
so I
mouse
will
1
be go.
second. Concentrate
Okay.
in this. Concentrate in this slice, please.
Okay, so calcified bilateral adrenal glands.
Yes.
These could be due to hemorrhage, prior hemorrhage, hematoma, or tuberculosis infection.
What else?
There is one syndrome with bilateral adrenal gland calcification. I couldn't recall the name.
Okay.
So, no definitive masses are associated to suggest neuroblastoma, and given the history negative of catecholamines.
Mm-hmm.
I
So
would
what's
like
your final
to
diagnosis?
adrenal glands calcification.
Okay.
I
What will
think
you do
I
next?
couldn't recall. So for correlation with the patient's history, if any history of adrenal hemorrhage during the neonatal period or uh,
Hmm.
ischemia or stress, like during delivery.
Look here at the
Okay, the
MRI.
MRI. So this is
T2.
MRI axial T2.
Look here again
Again, the
at
kidneys are
this area.
unremarkable.
Could you think this is bowel or lymph nodes? Look here. I give you the MRI to
Okay,
be sure is
I
this
think this is a lymph
lesions?
node.
Sure. Okay. What else?
Yes.
What else? But what about the spleen and the liver?
Okay,
Okay.
okay. The liver is high, showing high signal on this
Okay.
T2, and the spleen is low signal.
Mm-hmm.
So I would like to, and this is FAT study. So
Yes.
this is not fat infiltration. It could be due to like hemochromatosis or yes, mainly hemochromatosis.
Mm-hmm.
If any history of hematological disorder, however very young,
Okay. See, doctor.
hepatomegaly is there,
From the city, the
mild shaggy liver
main
cell.
concern, your main concern were in this region. Okay. Uh, did the MRI confirm your diagnosis or not? This is the first question you should ask yourself. Did the MRI confirm your diagnosis or not? Hello? Hello?
Yes, I had internet instability for a while. Yes,
Yes.
I'm
Did
back.
the MRI confirm your diagnosis or not? This and
Yes,
this.
it is abnormal adrenals bilaterally symmetrical
Okay. So, what
definitive mass
about the
lesion.
liver?
Yes,
What about the size of the liver?
is enlarged.
Okay. What about the size of a spleen?
Again enlarged.
Okay.
So
Okay. So,
hepatosplenomegaly.
yes, plus bilateral enlarged suprarenal gland and bilateral calcification, which proven by the CT. This is a syndrome, like you told. Okay. Even if you didn't know the name, but at least it looks like a metabolic syndrome. Okay.
Yes,
Uh,
yes,
okay. Thank you so much. It was a Woolman disease. What is the Woolman disease?
yes.
Normal deposition of fat within the adrenal glands and liver, spleen, and I think some lymph nodes. This is overall a syndromic deposition or a metabolic deposition of the fats. It is called Woolman disease. What is Woolman disease? What is Woolman disease? Differential diagnosis. The differential diagnosis, we should, as you mentioned, we should exclude other causes of bilateral, suprarenal, or adrenal gland calcification, like neuroblastoma. So we must ask the patient about any history of catecholamines lab investigation. Second, other symptoms of catecholamines, increased catecholamines like sweating, hypertension, like this. No any history. Other causes, hemorrhage. Okay, but hemorrhage and neuroblastoma will not associated with bilateral enlarged, enlarged hepatosplenomegaly. Plus, this is like you told, this is lymph nodes. Okay, why is this not lymphoma? Because I think the age of the patient, very young, 2 months, lymphoma is not common. Second point, the calcification here. Okay, the calcification here in the suprarenal indicate to another diseases other than lymphoma, like the list we just mentioned. I will add 2 points here. By the way, in T1, this is the normally the liver is of higher intensity more than the spleen. Normally. In T2, the spleen, I'm talking about the normal patient. Normal patient. This is abnormal, by the way. In T2, the spleen is higher than the liver. I'm talking generally, but here there are some pathology. Okay. So if we must revise T1 in phase and out of phase. I think this liver, if we get out of phase, I think this one, in and out. See, this is in, this is out, in, out, in, out, in, out. Okay, so this is fatty infiltration of the liver. How could we differentiate in phase and out phase? At least from the here, this is out of phase, but this is not the ideal exam because there are too much motion artifact. At least if you look here, you must see the Indian ink artifact here or the chemical shift. Okay, my colleagues. So
Okay.
it was a case of Wellman disease. What should I do in the exam? Like our colleague did. Okay, she found lymph nodes and she talked about lymphoma. But the examiner asked her, no, please look here. So she recorrected herself. Oh, doctors, there are bilateral non-symmetrical calcification, and she starts to mention the list of differential diagnosis. But she forget to tell about the other organs, hepatosplenomegaly. And the key here in this case is the other organ. Why? When you found hepatosplenomegaly in 2 months with bilateral suprarenal calcification and lymph nodes, your mind should be shifted to a metabolic disease, okay, or a systemic disease. Okay, my colleagues, is it clear for all of you? Here, why this is by the way lymph node? Why? Because look here, it is elevated the vessels. You were correct, Dr. Anagam, surrounding retroperitoneal here, but really the resolution is very bad, very bad. So, yani, you can't safely differentiate lymph node from bowel apart from this is the retroperitoneal here and the surrounding the aorta. Okay. Thank you so much. Here also, I think there are lymph nodes
Okay,
here.
thank you so much, sir.
Welcome. It was a difficult case, by the way. So the last case was Wellman disease. Wellman disease. Any question about this case? Yes, I told the question. Any para-aortic soft tissue? Yes, there are multiple peri and para-aortic lymph nodes. Candidate number 2. Candidate number 2.
Yes, sir, I'm candidate too. Yes,
Yes,
sir, I'm
request
candidate too.
yeah, request control.
Yes.
20-year-old female patient complaining of obstructive jaundice 2 weeks following the laparoscopic cholecystectomy. Request control.
Yes, sir. So I think
Okay, I
so. I'm not
will.
able to scroll, sir. Yeah, I think
Yeah,
yes. Yes.
yeah.
Yes, sir.
I'm
Yes, sir.
control.
You can
Yeah,
scroll.
yeah,
That
yeah,
would be better, sir.
yeah, yeah. Obstructive jaundice
So here I'm
post
provided
surgical.
with
Yeah.
T2-weighted MRI images of a female. These are the FAT-SAT images of a patient who has presented with obstructive jaundice. Okay, the cholecystectomy has been done. So now I'm just looking at the intrahepatic biliary radicals. I think, yes, I noticed that there is dilatation of intrahepatic biliary radicals noted. Confluence is seen. I'm just trying to see the common bile duct. Sir, I'm just trying to see the common bile duct. There is dilatation of intrahepatic biliary radicals. Okay, the common bile duct. I'm just looking at the common bile duct. I think there is some filling defects noted in this region, could be artifactual.
Yes. Which sequence do you want?
So the common bile. So at the region of confluent, I'm able to see some hypointensities at the region of confluence. I'm suspicious about these hypointense foci, which I noted at the confluence at the region of confluence.
Yes.
So in my routine practice, I would like to see the common bile duct and the pancreatic duct as well. So can I yes, sir.
What is the name of this sequence?
So on these. So these are the MRCP images, sir. Heavily T2 weighted images, sir. These are the 3D MRCP images. These are heavily T2 weighted. So on these are on the MRCP images. This again redemonstrates that there is dilatation of the intrahepatic radicals, and I can see that at the region of confluence, I'm able to see some filling defect noted at the region of confluence, and the distal common bile duct is not well visualized.
So what's your
So,
diagnosis, doctor?
and also I'm
What's
not
your...
able to. So, hilar
Yes.
cholangiocarcinoma is a yes, sir. So,
Okay.
I'm thinking in terms of hilar cholangiocarcinoma. So,
Yes.
I would like to see the post-contrast images as well. In my routine practice, I would
This
like
is
to
the
see the
post.
post-contrast images to look for
This
the
is the post.
contrast. So, on the post, I'm just quickly going through the post-contrast images. On the post-contrast images, I can see that there is some. I think this is the portovenous phase. So this is a portovenous phase, sir. In my routine practice, I would like to see the triple phase, all the arterial,
Okay, this is the
early
delayed one.
Okay. So on the delayed images, I can see that there is some enhancement in the region of uh in the hilar region. So this delayed enhancement, and there is also some capsular retraction. I think there's some capsular retraction noted as well.
Are you
So
sure?
these are in so mild capsular retraction is there, sir.
Are you
So
sure?
all these So I'm not very sure, but I think there is some capsular retraction. I think there is some capsular
Where?
retraction there.
Where?
So at this region, so here.
This one?
So in the lower section, I just noticed something was I mean, there was some indentation was there.
So what's your final diagnosis?
So, in this patient who is presenting with obstructive jaundice with intrahepatic with dilated biliary radicals, I'm thinking in terms of cholangiocarcinoma. I would convey
Mm-hmm.
my finding to the referring physician and would advise would advise histopathological correlation for further confirmation. This is an emergency. I would also advise urgent drainage, urgent decompression of the hepatobiliary system by placing a percutaneous transhepatic biliary drainage, and then the patient can be discussed at hepatobiliary MDT regarding further management.
Could you remember the history?
So the patient had cholecystectomy and the patient had
When?
jaundice.
When he has cholecystitis? How many years? How many days?
20 days back, I think. No, no,
2 weeks.
2 weeks, 2 weeks. Yeah, yeah.
And then before these 2 weeks, no obstructive jaundice.
Laparoscopic cholecystectomy.
Yeah. After the surgery, immediately he developed this
Okay,
obstructive
sir.
jaundice. So what's come in your mind? Post-operative. And there are
So
hypodense
could
filling
be,
defect not showing at all in the post-contrast. Nothing here. See, this is the left, this is the right. Follow?
yes,
This
sir.
is the convoluence area. This is here. Nothing here. So what's
Yes,
coming in
yes.
your mind?
So could be post-operative, could be post-operative scarring. So could be post-operative scarring or could be calculi, or they could be
Yes,
calculi in the could be calculi
yes.
in the
What
biliary
else?
duct.
What else?
Postoperative scarring. Postoperative scarring.
What else? Something iatrogenic.
Yes, sir. Iatrogenic. Yes, sir. Iatrogenic
Yes,
could
what
be
else?
possible.
What else? The surgeon bought something here by mistake.
Okay. Okay. Yes, sir.
He wanted to close the cystic artery, but he by falsely ligate the common hepatic. So what is this?
The clip, sir.
Yes. So what's your diagnosis?
Okay, this is
Iatrogenic.
bisected.
Yeah, ligation.
Okay.
Iatrogenic postoperative biliary duct ligation or injury. What happened? What happened? The history is very important. The history is very, very important. Even in this case, most of the examiner will not tell you the history. Patient develop recent obstructive jaundice. You will describe everything and you will talk about this one. This one is marked signal void. This is signal void.
Yes, sir.
Cholangiocarcinoma must show, especially in T2, any degree of signal, any degree of even mild high T2, even mild. But this is completely signal void, even here in T1. See,
Yes, sir.
in T1, I think this one, signal void also. So signal void means calcification, stone, or foreign body, like surgical clips. So we must ask, or we must remember the history very well. This is clips. Okay, doctor?
Yes. Yes, sir. Yes, sir. Yes, sir.
What
Thank you,
happened
sir.
here? Don't worry, don't worry. This is the left, this is the right. The right has two ducts. By the way, the left one has medial and lateral duct. The right, the right duct have anterior and I think posterior. Even here, this this one and this another one. Look here, the right biliary radical. Look, posterior and anterior. Uh, the biliary system completely follow the bifurcation or the segmentation of portal vein. How? The left portal vein has two left branches. One is lateral and one is medial. Two right, one posterior and one anterior. The same exactly in the biliary system. Okay, my colleagues. What is
Yes, sir.
this? This is a focal lesion here. If we follow, okay, from arterial venous delayed, finally it will be a hemangioma. But this is not a big deal. So the biggest deal to pick up the cache, the most important thing here. If you look here, what happened here? By the way, this is the common bile. Go up. At the convoluence here, no any biliary flow. So the obstruction is here. By the way, this is the MRCB seam images or يعني, movable images, dynamic. This is not dynamic, by the way. Same images. It's very important to follow each duct. Okay, even to follow the duodenum. Why we must follow the duodenum? Because in case of annular pancreas, you will find the second part of duodenum here. The caliber is stenotic. Okay, reduce the caliber here. What is this? This is the pancreatic duct we must follow. Also, we can rule out any pancreatic divisum through this pancreatic duct. If there are no joining, there are joining here. If this joining is not present, so you must suspect about the pancreatic disease. Okay, my colleagues, MRCB
Yes.
is so heavy, markedly heavy T2 sequence. Why? Because it nullify all the tissue except the fluid-sensitive tissue or the fluid-containing tissue, like the biliary duct and the duodenum here. Even you can see here, if you look posteriorly, see the kidney, you can see the pelvis. Or if you go, I think, posteriorly, you can detect the CSF, but here not seen. So it was a case of heterogenic ligation, post-operative ligation of the common hepatic. Post-surgical, we must be worried about injury and leakage or ligation. Doctor, in case of suspicion of injury, biliary duct injury and leakage, what is your next steps? Which
So,
contrast, which contrast should you give?
so non-ionic, I'm not sure. Some probably non-ionic low osmolar contrast.
What? No, I'm talking about the MRI. Which contrast, gadolinium or something else?
So I think hepatobiliary
Yes,
specific.
excellent. Hepatobiliary
Primoviscid.
and yeah, and we should wait until 60 minutes to allow
Yes.
the maximum accumulation of the contrast outside the biliary duct. Okay. Thank you so much, doctor. Next candidate. Next candidate.
Assalamualaikum.
Salam. 35 request control. 35-year-old female patient complaining of vomiting, epigastric pain for several days. Yes, go on.
I'm provided with the MRI images.
Let's start
So
with
I
this one.
cannot scroll.
Yeah.
So I am provided with the axial images of the MRI.
Yes.
This is titulated images in which I can appreciate. So I cannot scroll the images. Sir, please, can you scroll for me?
See, use the arrow. Use the arrow.
Okay. So I can appreciate that there is inflammatory changes noted in the peripancreatic region and in the right perinephric area. There is a fat straining.
Yes.
Gallbladder and liver appears unremarkable to me. Spleen is normal. Now I am looking for the cause of this fat straining and peripancreatic fluid.
Yes.
The head of the pancreas appears swollen and heterogeneous to me. No intrahepatic biliary channel dilatation noted.
So what's your diagnosis, doctor?
Sir, actually, I am having a problem in scrolling. Just give me a few minutes, few seconds.
It's scrollable.
So, so there is fat straining and fluid in the peripancreatic region, predominantly in the head of the pancreas. It could be due to a focal pancreatitis of the head with surrounding inflammatory changes.
Yes.
Now I look for the complications and cause of this pancreatitis. I will see gallbladder if there is any cholelithiasis, which I cannot appreciate on this MRI. I will see the ultrasound images. Second, I will look for the complications of pancreatitis on the post-contrast images. to
No
see any
postconcentration. This
vascular
is the postcon.
thrombosis.
Yes.
So this is the post-contrast image of abdomen, in which I can again appreciate. I'm looking at the vessels, portal vein. Scroll down.
I'm scrolling, by the way.
I'm looking for the portal vein. Portal vein is unremarkable. Looking for the septic vein for any thrombus, which appears normal to me. No thrombus is noted so far in any arterial or venous
So what's your
vessel.
diagnosis?
There are two ducts. Sir, there are two ducts which I can appreciate at the head of the pancreas. It could be due to pancreatitis due to pancreatic division. Because second part of the duodenum is also swollen to, it appears swollen to me. It can be a possibility that focal
So do you have a here?
So this is the MIP image from the MRCP, in which I can appreciate that.
This is MIB or this is volume rendering, 3D volume rendering. What is the better description?
Yes, this is volume rendered images.
Yes, 3D volume rendering.
Yes,
Okay.
I can.
By the way,
in which
3D,
I can appreciate
the 3D volume rendering, we can take it from the MIB. Okay. But the best description, in my opinion, this is a 3D volume rendering. Okay. What happened here, though?
Volume rendered image. I can appreciate pancreatic duct, which is slightly prominent at its insertion into the papilla. Common bile duct is also normal in diameter. I can appreciate that there is a separate drainage of pancreatic duct into the separate papilla and a separate insertion of common bile duct into the major papilla.
So finally, what's your diagnosis?
Pancreatitis due to pancreatic divisor.
Thank you so much, doctor. Look here, please. This is a pancreatitis. Okay. No any doubt. Why? Because the pancreatic head is enlarged. There are fluid about the surrounding the pancreas. All the signs. And the right pararenal, perirenal, left anterior perirenal. All okay. Okay. Everything is okay. But what is the cause? We must search for the cause. Like you did, you look at the common bile duct, there are no obstruction here, any stone, but what happened here? First mistake you did, you are describing about pancreatic divisum, okay, in T2. How come? Very difficult. You accuse yourself, you insinuate yourself in big problem, okay? Don't describe pancreatic divisum, and we have a more better sequence like this. This is the best to talk about the pancreatic duct, by the way. But from here, you can rule out something else. Doctor, follow with me the duodenum. This is the duodenum, okay? This is the duodenum. Okay, this is the duodenum. This is the duodenum. What happened here? What happened?
It is swollen and
no.
Edematous.
See, this is the duodenum. What is the name of the structure that's surrounding the duodenum?
Annular pancreas.
Okay. So in T2, it is better to rule out or to prove diseases related to sequence. Okay. This is again, this is the duodenum. This one. Okay. This one. Okay. See, this is the pancreas here. Pancreas, and this is the duodenum. I just said, I mean to say this information in the case before. I talk about the importance of the 3D MRCP. I told frankly, look at the duodenum, one of the most important, significant significance of the 3D is looking to the second part. This is the first one,
Narrowing,
or the
narrowing also.
market narrowing here. Here, market narrowing. Why? Because the pancreas suffocate or stenosed this part. And this image, this slide is very, very sufficient to diagnose annular pancreas, or at least tell the examiner the second part of the duodenum is stenosed. Attenuated caliber. Your next step to look at T2 or at T1. Anyway, any of them. Look here in the post contrast. This is the duodenum. This one, this is the third one. Go up. What the air make a good contrast. Go up, very clear here. This is the pancreas, this is the duodenum. So it was a case of annular pancreas complicated by pancreatitis. When we are dealing with a case of pancreatitis, we should rule out pancreatic deficit from here, or pancreatic annular pancreas from second part of duodenum, or even obstruction of ampulla of Vater by stones. Okay? Thank you,
Okay,
doctor,
sir.
so
Thank you,
much.
sir.
So the next case was the scenario of next case. The trick in the next case was about the cause. The cause and the complication was in the same slice. Okay, my colleague. Next candidate. Next
Yes, sir.
candidate.
Yes, sir.
Welcome.
I'm here, sir.
Welcome. 1 second. 8-year-old female patient complaining of abdominal distension and weight loss, no fever. MRI done to rule out malignancy. Can you request
Okay.
control?
Yes, sir. Sir, I have requested, sir.
Go on.
Okay, sir. Just 1 minute, sir. Sir, I am. Sir, I'm not able to. Yes, sir. I think I can. Yes, sir. I can scroll it now. Sir, I have been provided with the axial T2 weighted images of the abdomen and pelvis. I would like to scroll my set of images to have a look at the sequences. I'm sorry, sir, my net is a little bit slow, but I would
No
like
problem. No
to
problem.
scroll the set of images. I'm going towards the upper abdomen. On the first finding, which I can appreciate, is that there is moderate abdominopelvic ascites, which is appreciated. The visualized lung bases are unremarkable. The second, important finding which I can pick is that there is mental thickening as well. And the liver appears unremarkable. I can appreciate, I don't appreciate any pathology right now, but I would still like to scroll my set of images. Liver appears unremarkable, pancreas, I'm going down, and I can appreciate mental thickening as well. The patient had a history of abdominal pain. I don't, sorry. So these are just a set of the images now. I can't go down. So there, right now, the things which I can appreciate is that there is moderate abdominopelvic ascites, and there is there's a mental caking. So the most likely causes which I must be thinking right now would be that of the stomach thickening. And I would like to have a look at the stomach, and the stomach is underdistended, and I don't appreciate any gross thickening. These I have been provided with another axial set of images. I can appreciate that there is stomach thickening, but I am not sure because the stomach is not distended. I cannot appreciate, sir. Okay, I can. So these are the post-contrast images. I can appreciate that the peritoneum appears to be enhancing, and I can appreciate few peritoneal nodules as well along the thickening. A mental caking is there. I can appreciate that the liver, no focal lesion is appreciated within the liver parenchyma. So my most likely differentials would revolve around CA stomach and the CA ovaries. But I cannot appreciate any significant wall thickening within the stomach, so that is ruled out. And ovarian within the pelvis, I don't appreciate any ovarian mass lesion, but I would like to again have a look if I can, sir.
So what's your
There
diagnosis,
is
doctor?
Sir, there is peritoneal thickening with moderate abdominopelvic ascites. The most likely etiologies which I would like to be thinking would be that of infectious etiology. That can be a tuberculous etiology. Or the second thing which I would be concerning is that of a malignant cause, which I don't appreciate in this. I don't appreciate any mass lesion actually.
Is there
So
are
I
any
would like.
clue? Is there are any clue to differentiate between both of them?
Sir, sorry, sir, within, sir, there is mental caking, but in the lung windows, I don't appreciate, sir, there might be some consolidation in the right middle lobe, sir, in the right basal lung
Yes.
parenchyma.
So
So that might be
what's your
infectious
diagnosis?
etiology.
Okay.
So
Okay. What's your
tuberculosis,
tuberculosis? What?
tuberculous peritonitis, wet variety, and that is causing with both the pulmonary and the peritoneal involvement.
What's your
And
next
I would
step?
like. Sir, I would like to inform my referral and would like to involve a pulmonology team and would likely to suggest isolation of the patient along with the close screening of
What
the
is the most
contacts.
next?
Plus, I would.
What is the most
So,
common next? What is the second common site
sir,
of?
sputum evaluation.
1 second.
Sir,
1
that would
second.
be
What is
the
that?
spine,
1
spine and
second. Give
brain.
me, doctor, give me 1 second. What is the second most common location of tuberculosis infection in the body after the chest?
So that would be the spine,
No,
brain, sir.
no, in the abdomen, at least in the abdomen.
Okay, ileocecal valve, sir.
No. Okay. The genitourinary system.
Okay.
Genitourinary system is the
Okay.
second,
Okay.
the second system after the chest. Okay.
Mm.
Thank you, doctor.
Okay.
It was
Oh.
a tuberculous peritonitis. What happened here? You are presented with a case of ascites and you are
Mm.
searching for a cause. Like number one,
Mm.
liver. The liver looks like
Mm.
normal. Sorry, we'll start from here. The liver looks like normal. No portal hypertension is normal. So you are
Yes.
searching for a malignancy. Oh, doctor, what happens? There are a dirty mesenteric, peritoneal or mesenteric caking. Okay.
Mm.
So we are
Yes.
searching with something in the abdomen, either tuberculous
Yes.
or malignancy. When you see this caking, keep in mind both of them. If I am in your situation, I will go first to the lung. First.
Okay.
I think there were something here. This one. This one. Okay.
Mm.
At
Okay.
least this is fat cell, by the way, to rule out any pericardial fat. This is not pericardial fat. This is the pericardial fat which is suppressed. So there are something here. Looks like consolidation. Okay. Then we go
Mm.
down. Oh, this is the enhanced mental kicking, and this is the peritonitis. So number one, this is TB. Number two, I will tell the examiner I should rule out any stomach, like you did very well. Okay, stomach or ovarian.
Okay.
If the patient, this is female. Okay, if the
Mm.
patient is female, I will go first to the ovarian location to rule out any masses, cystic masses, anything. This is normal. Second, I
Mm.
will rule out any stomach. Like this, the examiner will be very happy. Why? You looks like a surgeon. You know
Mm. Mm.
the sites of pathology. Okay.
Okay.
When I
Okay.
am presented with a peritonitis or a peritoneal pathology with ascites, I should rule out 1, 2, 3. I think the examiner will be happy, even you didn't give him the final diagnosis. I will rule out any lung pathology to rule out TB. Okay.
Okay.
And then
Okay.
if no lung pathology, I will rule out stomach cancer. If I will rule out any malignancy in the ovaries. Like this, he will
Oh.
be very happy. It was a case of peritoneal tuberculous peritonitis. Tuberculous peritonitis. Very
Okay.
important. The TB is
Oh.
very important. By the way, here, no any cecal, because the cecum and a part of terminal ileum is very common to be affected. If you look here, the cecum is nearly normal. When I preparing this case, the first thing that I do, I go to the cecum, I found it normal. Then I go to the lung. Even the lung only is seen, the pathology is seen in one sequence. And this is the scenario of the exam. You will not find the lung pathology or the key of the case in all the sequence, maybe in one. This case is very commonly to come in long cases. Very common. Why? If you see here, the key in one sequence only. Thank you, doctor, so
Okay.
much.
Thank you, sir.
Next candidate. Next candidate.
Yes, doctor.
Leave the mouse, last candidate, please.
Yes, sir, I am. So just 1 minute.
Okay. In case of biliary injury, we give a Primovest and we will wait for 60 minutes. 60. 60. Why? Because we want to give more time for contrast to leak from the biliary injury and to accumulate in a considerable amount that we can detect by the MRI. 60. What is the reference of this information? One of Dr. Khan lecture, because you will not find this concept or information at any site or any book. I listen this answer in one of Dr. Khan lecture. This patient, doctor request control, 70-year-old male patient complaining of abdominal pain. يلا go on.
Okay, I'm presented with 70 CT abdomen axial cuts in arterial phase. In a patient presented with a history of pancreatitis, it's a portovenous phase, sorry. I'm
Scroll,
scrolling
doctor.
from up to
Doctor,
down.
what? See.
Yes.
You take about 6 or 7 seconds talking without scrolling. This is not in your benefit. Scroll while talking with the examiner.
Okay. Okay. I'm going from top to bottom image before commenting. I can see the pancreas. History of pancreatitis. It looks normal to me. The stomach is collapsed. Liver appears remarkable. Gallbladder also. There is a thickening of the anteroparinal fascia. Oh, sorry. There is soft tissue mass encapsulating the aorta and
Yes.
it's not scrolling. It's not scrolling, sorry. And causing mild narrowing of the aorta until it is starting from the suprarenal until the bifurcation of the aorta and the two the common iliac vessels. I am thinking of this retroperitoneal fibrosis, so I have to check the kidneys for any hydronephrosis. There is a prominent of both pelvic calcium system. I do not see any other renal lesions. I have to check, scroll down. There is some stranding also in the pelvis. Okay, so my primary diagnosis for this is retroperitoneal fibrosis with mild bilateral nephrotic changes. As the pancreas was normal, I am just have to search for this other IgG for related autoimmune autoimmune
Yes,
yes. So the pancreas was normal, so there is no autoimmune pancreatitis. So I have to check any history for the patient, history of thyroiditis, and I will check also by ultrasound for thyroid for renal thyroiditis if there is any history of pseudo-orbital pseudotumor. I will also, if there is any neurological symptoms, I have to check for any like hypophysitis associated with IgG for disease. There is also, I have to check the liver if there is
diuretic
any
system.
biliary. This I will urgently refer the person for clinical team for possible insertion of for drainage of this hydronephrosis. I have also to check for serum markers for this IgG4. Recommend steroid therapy. I do not see any
What is
associated
your next
biliary radical.
radiological examination for this patient?
Next radiological. Assess
Yes.
other associations. Assess other associations like renal thyroiditis by ultrasound and brain
Okay.
hypophysitis by MRI. Yes,
Okay, look here.
yes. This is
One
I'm
second,
presented with
second here. Or take a look one second. Look here. What happened? Look here. What happened here?
I see there is
This is 1 year follow-up of the patient. What happened? Look at this slice. What happened?
there is I do not see this soft tissue surrounding the aorta.
Okay.
Yes, it's decreasing. So it's after
Markedly decrease.
treatment, this
Okay,
yes,
what
market
happened
decrease.
here?
This autumn.
Look,
Mm.
do you have any
Uh,
change? Look here. Look.
there is some biliary intrahepatic biliary radical
Okay.
dilatation.
Why?
This because this could be primary associated with sclerosing cholangitis and the outscope of this IgG for related disease. Um, I don't know if there is serum markers for if there is activity of
Did you
this
find
disease.
any clue, doctor? Did you find any clue?
Yes.
Hmm?
For this intrahepatic biliary radical, I have to check for associate I first to trace the common hepatic duct until
Yes,
the
yes or no? Did
pancreas
you
and
find? Yeah. Did you find anything?
no, no,
Sure? Are you sure? Look again.
no.
Please follow the common
This
bile. Follow.
yes, it is dilated. Yes,
And what happened here?
this abrupt cut off.
Yes.
It's narrowed now. I think there is some thickening in the distal common bile duct.
Yes, and thickening and
Surrounding fat
enhancement.
stranding. Enhancement,
No,
yes. So
enhancing.
this
Yes.
going
So
with cholangitis, yes. This
what
going with cholangitis,
is what type of cholangitis? Ascending, sclerosing?
ascending.
No.
Because
Ascending
it's starting from
cholangitis.
down, I think.
No. Ascending cholangitis means infection. But in autoimmune disease, the correct name is sclerosing cholangitis. Okay,
Sclerosing, yes.
okay.
Yes.
So summarized.
To summarize the case, this patient is IgG4 related disease with history of this retroperitoneal fibrosis and newly developed this sclerosing cholangitis. I would refer the patient for the clinical team for management of this retroperitoneal
If
fibrosis.
the clinician insists to get a biopsy from this lesion, could you describe me the technique? Which technique? Technique means which side, from which direction will you insert the needle? Very simple. And you must, I will explain a little bit about CT guided biopsy. In CT guided biopsy, the technician make first a plain CT and then show to you that the CT, and you and the technician choose a slice using a laser, 2 lines of laser. This is guide your needle. Okay, suppose there are a laser here. Okay, and first you must choose which slice do you want to take a biopsy from. Tell me to stop. Could you take from this
Actually,
one? Can you take from this one?
I don't know actually.
Why?
I think after the kidneys, after the end of
The
both kidneys
technician
lower
told you
down,
this
I
is
think.
very, very suitable. What's your answer? This slice is very good.
No, this, I think this is the origin of the renal hilum, so I should go
Okay,
down
there
below
are
the renal
vessels
hilum to
and
avoid
the bowel
injury.
here. Yes, vessels and bowel. From where?
I, I have to go down, I think, after the kidneys finish.
Kidney fin. Okay. Here? From here?
I think
I
just
will.
above the bifurcation. I'm not sure.
Okay, I will answer you. I will answer. See here,
Yes.
you must also look here at the entry. Can you enter from this? Very difficult. There are a bowel and the vessels here. So don't choose the right axis. Look here. The left axis at this slice is the most accessible, especially here. If I insert the needle from here, left oblique,
Yes.
or from here, and the needle should be, I will draw like this. I can go like this. Why? To be away from the aorta. And I will avoid this bowel. You can go from here by the needle. Okay. Sorry. You can go from here. And inside this fat, you can change a little bit your axis. You can come like this. Okay. Like this.
Okay.
But this axis is very good, very accessible. Why? Empty here. No bowel, no vessels. Even the site of biopsy here, it is very difficult to biopsy. By the way, any biopsy besides the aorta is very fatal. It must be done through a very professional interventional radiologist. But this question may be asked in the exam. Can you go through this? No. Here? No. Somebody may ask you, okay, lies a patient prone and take from here. Very difficult. Very difficult. Very long, very difficult. This is very easy. Okay. But in case of paraspinal lesions here, or just beside the psoas major, okay, or psoas major abscess, you may go through the back, both the patient prone, and insert your needle like this. Is it clear?
What I was thinking
Choosing,
about, yes.
choosing the safe two concept must be fulfilled during a biopsy. Number one, safety. Number two, accuracy. Okay, very important. Thank you so
Okay.
much.
Thank you.
Next candidate. Leave the mouse.
Yes, I'm here.
Uh, Doctor, this patient is
Yes.
55-year-old male patient complaining of vomiting, nausea, and lower chest pain. Go on.
Okay. I'm presented with the frontal chest X-ray. I cannot see any striking abnormality, so I will go through my checklist. I can see clear both lung fields, normal heart size, slightly prominent hilar vessels, normal skeleton. I can see that the gastric air bubble shows some thickening and thumbprinting, I think. No retrocardiac shadow or mediastinal shift.
Yes.
I would like to sorry, can you tell me the history again?
Lower chest pain, vomiting.
Okay, so I'm suspecting abnormality in the stomach. So
Yes.
I would like to review any other studies for the patient and proceed with CT abdomen with contrast and oral contrast.
CT and contrast. Go on.
Can I request control?
Yes, yes.
Okay.
Go on.
Okay.
Go on.
Okay. Now it's correct. I'm presented with axial non-contrast CT with oral contrast. I can see a thickening of the stomach wall appreciated at the antrum and pylorus. With the nodularity, minimal fat surrounding, fat stranding. At the at this cut, I can see a pedunculated lesion at the wall of the stomach, um, protruding inside the abdomen. I will look for any lymph nodes inside the abdomen.
What's your professional diagnosis?
My provisional diagnosis will be just tumor, or adenocarcinoma of the stomach. I cannot see any.
Okay, what is your next step?
I would like to do MRI for the patient. MRI abdominal contrast.
This is MRI.
Okay.
Yeah.
Okay.
Look here, here. What did you found?
Well, I can see that increased fold thickness and thickening of gastric folds, yet no definite mass.
Sure? Are you sure? Are you sure? No definite mass. Look here.
I can't scroll anymore.
Give me scrolling. Look here.
Okay, there is evidentiated mass, yes, attached to the lesser curvature of the stomach,
And what else?
and the pylorus,
Okay.
and and first part of the duodenum.
Yes,
My
excellent.
primary
Hmm.
diagnosis will be Linnitis plastica.
What else? Do you think,
Um,
1 second, leave the mouse, leave the mouse, leave the mouse. 1 second.
okay.
Do you think if this Linnitis plastica, the lumen will be like this?
No, it
The
would be
second
markedly
point, do you
narrow.
think Linnitis plastica extend in the duodenum without any extra luminal extension?
Um, no.
Okay, it may be a
Um,
possibility, but what is other possibility? Maybe another
lymphoma.
possibility. What else? There are no lymph nodes. Spleen is normal. What else?
Yes. Um, um,
What else? Something benign in the stomach and duodenum.
Meniere's disease, I think.
Okay, but Meniere's disease will affect all the region.
Yes. Yeah. Yeah.
What about benign causes? The stomach and the duodenum is one of the most common sites of adenosis, polyposis.
lipos, yeah, okay.
Yeah, could this one be multiple polyps or multiple adenomas? Could be.
Yeah, sure. Yes.
Especially it looks like benign. Why? Look,
Yes.
very large granulated mass filling the
Yeah.
pylorus, duodenum. Without it, look at this black line. This is cirrhosa and the muscularity mucosa is not at all infiltrated. So it is a sign of benign lesion. So I must think number one about multiple adenomas or polyposis. At least I will tell the exam doctor looks like benign. So I'm thinking about polypoidal syndrome, like whatever.
Okay.
What is the most common syndrome that contain stomach and the duodenum? Stomach and the duodenum only polyps. If you look at the rest, for example, at least the colon, you must rule out see the colon. The colon is looks like normal, no any
Yeah.
polyps, even rest of the small bowel. So we're talking about syndrome that affect stomach and the duodenum with adenomas and the polyps. Okay.
Yeah.
What is the most common one? By the way, the patient have some skin pigmentation. I think
Pets
skin
sugar, yeah. Pets sugar.
Jagger or
Yeah.
concrete Canada.
Oh, okay.
It was at least if you didn't know the names, at least tell the examiner this is a syndromic polyposis or adenomas of the stomach and duodenum. Doctor, I'm worried
Okay.
about other associated malignancy. Like in this one, there are in Cronchit, Canada. This one, there are other malignancy like in the breast. Breast may have a carcinoma in this Cronchit, Canada. I think also the brain have a glioma. Let's show you here. So the most important here is the syndrome itself, but also the association. Association in Cronchit, Canada, as I told you, there may be an association of breast or brain carcinomas. Okay, my colleagues. So the
Okay.
last case was Cronchit, Canada syndrome, and this is one of the GIT adenomas and the polyposis syndrome. Thank you for all of you, my colleagues, for today. Let's meet. I think it is better to change as regard some suggestion of our colleagues. Almost I will change to Sunday and Wednesday. Thank you for all of you. Thanks for our coordinator. Goodbye.